Fecal occult blood, Wikipedia audio. Fecal occult blood refers to blood in the feces that is not visibly apparent. A fecal occult blood test checks for hidden blood in the stool. Other tests look for globin, DNA, or other blood factors including transferrin, while conventional stool guaiac tests look for heme. Fecal occult blood testing, as its name implies, aims to detect subtle blood loss in the gastrointestinal tract, anywhere from the mouth to the colon. Positive tests may result from either upper gastrointestinal bleeding or lower gastrointestinal bleeding and warrant further investigation for peptic ulcers or a malignancy. The test does not directly detect colon cancer but is often used in clinical screening for that disease, but it can also be used to look for active occult blood loss in anemia or when there are gastrointestinal symptoms. Medical uses. The stool guaiac test for hidden blood in the stool can be done at home or in the doctor's office, or can be performed on samples submitted to a clinical laboratory. Testing kits are available at pharmacies in some countries without a prescription, or a health professional may order a testing kit for use at home. If a home fecal occult blood test detects blood in the stool, it is recommended to see a health professional to arrange further testing. Gastrointestinal bleeding has many potential sources, and positive results usually result in further testing for the bleeding site, usually looking for lower gastrointestinal bleeding before upper gastrointestinal bleeding causes unless there are other clinical clues. Colonoscopy is usually preferred to computerized tomographic colonography. 10% cancer, 20–30% adenoma or polyps, diverticular disease, hemorrhoids, inflammatory bowel disease, angiodysplasia of the colon, sickle cell anemia. An estimated 1–5% of large tested populations have a positive fecal occult blood test. Of those, about 2–10% have cancer, while 20–30% have adenomas. A positive test can result from upper gastrointestinal bleeding or lower gastrointestinal bleeding. The common causes are: in the event of a positive fecal occult blood test, the next step in the workup is a form of visualization of the gastrointestinal tract by one of several means. Although red or black stools can be an indication of bleeding, a dark or black color can also be due to black licorice, blueberries, iron supplements, lead or Pepto-Bismol, and a reddish color can result from artificial or natural colorings as found in red sweets, or large quantities of beets. Screening methods for colon cancer depend on detecting either precancerous changes such as certain kinds of polyps or on finding early and thus more treatable cancer. The extent to which screening procedures reduce the incidence of gastrointestinal cancer or mortality depends on the rate of precancerous and cancerous disease in that population. GFOBT and flexible sigmoidoscopy screening have each shown benefit in randomized clinical trials. Evidence for other colon cancer screening tools such as IFOBT or colonoscopy is substantial, and guidelines have been issued by several advisory groups but does not include randomized studies. Fecal immunochemical testing, an immunochemical fecal occult blood test. FIT products utilize specific antibodies to detect globin. FIT screening is more effective in terms of health outcomes and cost compared with guaiac FOBT. According to the guidelines of the American College of Gastroenterology, annual fecal immunochemical testing is the preferred colorectal cancer detection test. A FIT test detects globin levels in feces at or above 50 nanograms per ml, the established cutoff by the World Health Organization for colorectal cancer screening. In 2009, the American College of Gastroenterology suggests that colon cancer screening modalities that are also directly preventive by removing precursor lesions should be given precedence, and prefer a colonoscopy every 10 years in average-risk individuals, beginning at age 50. The Act suggests that cancer detection tests such as any type of FOB are an alternative that is less preferred, and if a colonoscopy is declined, the FIT should be offered instead. Two other recent guidelines, from the U.S. Multi-Society Task Force and the U.S. Preventive Services Task Force, while permitting immediate colonoscopy as an option, did not categorize it as preferred. The AC and MSTF also included CT colonography every 5 years, and fecal DNA testing as considerations. All three recommendation panels recommended replacing any older low-sensitivity, guaiac-based fecal occult blood testing with either newer high-sensitivity guaiac-based fecal occult blood testing or fecal immunochemical testing. MSTF looked at 6 studies that compared high-sensitivity GFOBT to FIT, and concluded that there was no clear difference in overall performance between these methods. The American College of Gastroenterology has recommended the abandoning of GFOBT testing as a colorectal cancer screening tool, in favor of the fecal immunochemical test. Though the FIT test is preferred, even the guaiac FOB testing of average-risk populations may have been sufficient to reduce the mortality associated with colon cancer by about 25%. With this lower efficacy, it was not always cost-effective to screen a large population with GFOBT. Source of bleeding. If colon cancer is suspected in an individual, fecal occult blood tests may not be clinically helpful. If a doctor suspects colon cancer, more rigorous investigation is necessary, whether or not the test is positive. In 2006, the Australian government introduced the National Bowel Cancer Programme, which has been updated several times since. Targeted screening will be done of all Australians aged over 50 to 74 by 2017-2018. Cancer Council Australia recommended that FOBT should be done every 2 years. Gradually, government fund disbursement meant that some people are not yet eligible for the national program and should pay for a FOBT by themselves. The Canadian Cancer Society recommends that men and women age 50 and over have a FOBT at least every 2 years. In colon cancer screening, using only one sample of feces collected by a doctor performing a digital rectal examination is discouraged. The use of the M2PK test is encouraged over GFOBT for routine screening, as it may pick up tumors that are both bleeding and non-bleeding. It is able to pick up 80% of colorectal cancer and 44% for adenoma 1 cm, while GFOBT picks up 13 to 50% of colorectal cancers. An extensive literature has examined the clinical value of FOBT in iron deficiency anemia. Conditions such as ulcerative colitis or certain types of relapsing infectious diarrhea can vary in severity over time, and FOBT may assist in assessing the severity of the disease. Medications associated with gastrointestinal bleeding such as bortezomib are sometimes monitored by FOBT. Stool color. Colorectal cancer screening. The use of tests for fecal occult blood in disorders of the mouth, nasal passages, esophagus, lungs, and stomach, while analogous to fecal testing, is often discouraged, due to technical considerations including poorly characterized test performance characteristics such as sensitivity, specificity, and analytical interference. However, chemical confirmation that coloration is due to blood rather than coffee, beets, medications, or food additives can be of significant clinical assistance. Iron deficiency anemia, gastrointestinal disease and medications. Testing secretions for occult blood. Regulatory impact. Marathon runners. Safety regulations from U.S. accreditor. The Joint Commission may have unintentionally decreased digital rectal examination and FOBT in hospital settings such as emergency departments. Gastrointestinal complaints and low-intensity GI bleeding frequently occur in marathon runners. Strenuous exercise, particularly in elite athlete runners and less frequently in other exercise activities, can cause acute incapacitating gastrointestinal symptoms including heartburn, nausea, vomiting, abdominal pain, diarrhea and gastrointestinal bleeding. Approximately 1/3 of endurance runners experience transient but exercise-limiting symptoms, and repetitive gastrointestinal bleeding occasionally causes iron deficiency and anemia. Runners can sometimes experience significant symptoms including hematemesis. Exercise is associated with extensive changes in gastrointestinal tract physiology, including diversion of blood flow from the GI tract to muscle and lungs, decreased GI absorption and small intestinal motility, increased colonic transit, neuroimmunoendocrine changes in hormones and peptides such as vasoactive intestinal peptide, secretin, and peptide histidine methionine. Substantial changes occur in stress hormones including cortisol, in circulating concentrations and metabolic behavior of various leukocytes, and in immunoglobulin levels and major histocompatibility complex expression. Symptoms can be exacerbated by dehydration or by pre-exercise ingestion of certain foods and hypertonic liquids, and lessened by adequate training. Ingestion of 800 mg of cimetidine 2-HR before running a marathon did not significantly affect the frequency of gastrointestinal symptoms or occult gastrointestinal bleeding. Conversely, 800 mg of cimetidine 1-HR before the start and again at 50 miles of a 100-mile running race substantially decreased GI symptoms and post-race GWAS test positivity but did not affect race performance. Nomenclature. In 2007 the nomenclature of overt, obscure, and occult bleeding was clarified. There are 4 methods in clinical use for testing for occult blood in feces. These look at different properties, such as antibodies, heme, globin, or porphyrins in blood, or at DNA from cellular material such as from lesions of the intestinal mucosa. FIT testing has replaced most GFOBT tests as the colon cancer screening test of choice. This methodology can be adapted for automated test reading and to report quantitative results, which are potential factors in design of a wide-scale screening strategy. The number of fecal samples submitted for FIT may affect the clinical sensitivity and specificity of the methodology. High-sensitivity GFOBT tests such as Hemoccult Sensor remains an accepted option, and may retain a role in monitoring gastrointestinal conditions such as ulcerative colitis. However, the FIT test is preferred in recent guidelines. Additional methods of looking for occult blood are being explored, including transferrin dipstick and stool cytology. The estimates for test performance characteristics are based on comparison with a variety of reference methods including 51 chromium studies, analytical recovery studies and spiked stool samples, analytical recovery after ingestion of autologous blood, rarer studies of carefully quantified blood instilled at bowel surgery as well as other research approaches. Additionally, clinical studies look at variety of additional factors. In healthy people, about 0.5 to 1.5 ml of blood escapes blood vessels into the stool each day. Significant amounts of blood can be lost without producing visible blood in the stool, estimated as 200 ml in the stomach, 100 ml in the duodenum, and lesser amounts in the lower intestine. Tests for occult blood identify lesser blood loss. Fecal immunochemical testing can identify as little as 0.3 ml of daily blood in the stool, yet this test threshold doesn't cause undue false positives from normal upper intestinal blood leakage because it does not detect occult blood from the stomach and upper small intestine. Thus the FIT test is much more specific for bleeding from the colon or lower gastrointestinal tract than alternatives. The detection rate of the test decreases if the time from sample collection to laboratory processing is delayed. Processing the sample in under 5 days from collection is recommended. Methodology: Stool Guaiac test for fecal occult blood sensitivity varies depending on the site of bleeding. Moderately sensitive GFOBT can pick up a daily blood loss of about 10 ml, and higher sensitivity GFOBT can pick up lesser amounts, requires at least 2 ml to become positive. The sensitivity of a single stool Guaiac test to pick up bleeding has been quoted at 10 to 30%, but if a standard 3 tests are done as recommended, the sensitivity rises to 92%. Reduced patient compliance with the collection of 3 samples hampers the usefulness of this test. Further discussion of sensitivity and specificity issues that relate particularly to the Guaiac method is found in the Stool Guaiac Test article. Fecal porphyrin quantification by HemoQuant can yield a false positive result due to exogenous blood and various porphyrins. HemoQuant is the most sensitive test for upper gastrointestinal bleeding and therefore may be most appropriate fecal occult blood test to use in the evaluation of iron deficiency. Advised to stop red meat and aspirin for 3 days prior to specimen collection. False positives can occur with myoglobin, catalase, or protohemes and in certain types of porphyria. Test performance: Fecal DNA tests as of 2008 had not been well studied enough to support widespread use. Reference standards: Gastrointestinal blood loss, clinical sensitivity and specificity.